almost certainly with Lasix you have to be on a potassium supplementation. So again, the side effects, if you overshoot the mark and the patient becomes dehydrated, they get a dry mouth, they get low blood pressure, so you have to back off. Potassium depletion we talked about. A rare side effect is hearing disturbance, but that's very uncommon. And fatigue just from low blood pressure. So they're good drugs, but perhaps more for heart failure than they are for hypertension. Potassium sparing diuretics were mentioned. This drug spironolactone, it works here, and so basically it exchanges sodium for potassium. So the urine that comes down here, it makes you resorb the potassium and excrete the sodium. So again, they're very good in combination with, say, the thiazides or the loop diuretics, because they retain potassium and they excrete sodium. So again, very commonly used in heart failure, probably underutilized in patients with hypertension. And the reason for that is, particularly in males, they have an estrogenic effect and they get basically enlarged breasts and nipple soreness, we call gynecomastia. So a lot of guys, maybe 20% of males who have it, don't like that and it's severe enough to stop it. It's not so much an issue with females, but it makes females grow hair. So you'll get moustaches and beards, and so not all the time, but that's a side effect females don't like. In some ways, it's used for patients who are losing their hair, however. So if you've got thin hair in an elderly female, aldosterone antagonists will often help reduce that, because it sort of stimulates hair growth because of the androgenic effect. So in some ways it's good for elderly females, but a lot of men don't like that sensation of getting sort of lumps in their breasts and sore nipples. And so sometimes we're in a dilemma where we say it's good for your heart, but you've got that side effect. There's various ways. Sometimes you say put a little band-aid across your nipples so it doesn't irritate you. Or we've had people where the surgeon will operate, take out the breast tissue so you can continue to use it. So that's pretty extreme, but in heart failure it can be a life-saving medication. So we try and really encourage patients to stay on it. Now, beta blockers are an old class of drugs. As I said, beta blockers and diuretics for many years were the mainstays of treatment. There's various beta blockers in the system. There's beta 1 receptors, which are primarily in the heart, and beta 2 receptors, which are primarily in the lungs. And the beta blockers we have basically block both. Now, beta 1 blockade is good. Beta 2 blockade is not so good for people if they've got a tendency to asthma. So if you've got an airways disease problem or asthma and use a beta blocker, it can often make it worse, because it blocks the beta 2 receptors in the lung, which are the receptors that cause your airways to open up. So things like Ventolin and those type of drugs are what we call beta 2 agonists. So they stimulate the beta receptors in the lung, open up the airways and reduce asthma. So these drugs have the opposite effect. They constrict the airways, and so if you've got a tendency to asthma, you would not use them. So as in response to that, they've developed agents that are more and more beta 1 specific and less beta 2 specific. So you try and use them for both hypertension and for heart failure. What they do is they dampen down the heart rate, so you cause a bradycardia, and we ideally try and get the heart rate between 50 and 60 in patients with heart failure with them. Not so important with hypertension. We try and use agents to stimulate primarily beta 1 receptors and beta 2. So things like bisoprolol and nebivolol are the agents who are more specific for beta 1. Things like atenolol and metoprolol are better. And then you've things got like propranolol, which stimulates both. So if there's any suggestion of airways disease, you try and use a more beta 1 selective agent, such as I said, metoprolol, atenolol, bisoprolol, nebivolol. They also are used in heart failure, because we know that in patients with a failing heart, they get an upregulation of beta 1 receptors, and that impairs LV function. And so by blocking that adrenergic drive to the heart, you get a improvement in cardiac function. And just to give you an example of the magnitude of benefit of that, when these drugs were introduced in Australia for heart failure, the cardiac transplant list at the Alfred Hospital went down by 50% in 6 months because they were so effective at improving heart function. So certainly for heart failure, they're a life-saving drug, really improved prognosis, and we think there's standard treatment for that. For blood pressure, we've gone away from them a little bit because there are better agents like ACE, ARB, calcium blockers, spironolactone, but we would still use them as third line, fourth line agents. The other good part about them is that they're antiarrhythmic. So if you've got patients with AF or you have ventricular arrhythmias, they're very helpful in suppressing them as well. But for blood pressure, we tend to go away from a bit because of the availability of these other agents. Now, anticoagulants, that's a means of thinning the blood and making it less likely to form blood clots. And we do that in various circumstances. We would do it if a patient has recurrent thrombosis in any part of the body, so DVTs, pulmonary embolism. We use long-term anticoagulation for that. We use it in patients who have atrial fibrillation, which is a condition where you get an irregular heartbeat so that the heart can't empty blood properly. You get blood clots forming that break away and can cause a stroke. And so for that population, we recommend anticoagulation to reduce the risk of having a stroke. The other context we use them in is if people have had a heart attack. We use anticoagulation to try and prevent further thrombosis in the arteries in the heart. And the fourth one, I suppose, is people who are sick in hospital are more prone to get thrombosis in the legs and DVT. So we use prophylactic or preventative anticoagulation to stop them getting a DVT and pulmonary embolus. So basically, thanks very much. There's several different types. There's antiplatelet agents, which basically block platelet function, and they're a tablet form. There's anticoagulants, which can be oral, which would be warfarin, or the new agents called NOACs, which are alternatives to warfarin. And then there's the injectables, which would be standard heparin or low molecular weight heparin, so standard heparin is an infusion, low molecular weight heparin is an injection once or twice a day. If you've got a person on anticoagulation, you want to do everything you can to reduce the risk of bleeding, because obviously if you thin the blood and make it less likely to clot, and you have something that bleeds, well, you bleed much more. So we try and minimise the chances of that and say, let's try and stop medications that can potentially increase the risk of bleeding so that we can use these drugs more safely. So things like aspirin, we would try and stop it if we could. Things like non-steroidals, like naproxen, brufen, those sort of things. Prednisolone increases the risk of bleeding. Various other agents, cephalosporins, hydroxychloroquine, less so. But the common ones would be aspirin, non-steroidal, prednisolone, and if we can cut them out, if possible, reduces the chances of bleeding. Heparin is the mainstay of anticoagulation. There's unfractionated heparin, which is injected into a bag and then run as an infusion. You try and keep the APTT, which is a measure of how thin the blood is, between 60 and 90, and that indicates an adequate level of anticoagulation to thin the blood, but not make it too thin that people bleed. Often you have to do a blood test 2, 3, 4 times per day to make it keep it in the right range. You have to adjust the doses up and down according to the patient's weight, to their renal function, other drugs they're using. So it's a good drug, but it's a bit of a pain to use clinically. Its advantage is that you turn off the heparin infusion and within an hour it's gone, so you're back to normal. So that's an advantage. The disadvantage is frequent blood tests and having an infusion pump that people have to pay attention to. The alternative to it is what we call low molecular weight heparin, which is an injectable. You have, depending on which agent, twice a day is the most common one, clexane. You adjust the dose according to body weight, according to renal function, and its advantage is it's just a subcutaneous injection you give twice a day. You don't have to do blood tests, you don't have to do monitoring. Its disadvantage is that if you give an injection, it doesn't wear off for 12 hours. So if you've got a patient who perhaps needs surgery or something done to them and you've given them clexane, effectively you have to wait 12 hours before you can operate or do whatever safely. Whereas with the IV unfractionated, you turn it off and you can have whatever a couple of hours later. So if you think a patient's going to need to have a bypass, for example, you'd use unfractionated heparin intravenously. If you think a patient's stable and going to have a procedure in 3 or 4 days, you use the injections. But it reduces nursing time, it makes it so much less complex for the patient, but we use both in various circumstances. It's, again, the side effects in both of these are bleeding, so you look to do whatever you can to reduce other risk factors for bleeding. So basically, the way heparin works is basically it blocks the conversion of prothrombin to thrombin and the activation of fibrinogen, and so you decrease the activation of fibrinogen to fibrin. So it acts as a non-specific blocker of the coagulation system. Side effects we mentioned, hemorrhage, any blood thinning agent, whether it be an antiplatelet, whether it be an antithrombotic, increases the risk of bleeding. As with all drugs, there's allergic reactions and they're very uncommon. And the other uncommon but pretty bad effect of heparin is you can get heparin-induced thrombocytopenia, which means your platelet count goes very low, and that can be life-threatening. You can get virtually no platelets, and that really increases the chances of bleeding. And that becomes difficult because then if the patient needs anticoagulation, you have to use alternatives. So it's a difficult situation. The other agents that can affect it are listed there: antihistamines, DIG, some of the herbal things like ginkgo biloba, nicotine. I think they're theoretical more than practical considerations. So they're, you ask about ginkgo biloba because that has an antiplatelet effect. The rest of them I wouldn't be too concerned about. Where are we? Sorry. Okay. So as I mentioned, low molecular weight's an alternative. It has lower rates of bleeding than heparin because you get a stable level rather than going up and down according to the dose you're using. It works the same way as heparin, but just a more purified form of heparin that you can inject subcutaneously. The main one we use here is clexane or enoxaparin. There's one called dalteparin that's called Fragmin that we seldom use these days, but that clexane would be the standard low molecular weight heparin pretty much all throughout Australia. The oral anticoagulants are the two forms. Now, warfarin again is the standard anticoagulant that we've had for 50 years, and until more a decade ago, we really had no alternative to warfarin. It works by affecting the vitamin K dependent clotting factors. So the way to remember them is the TV stations. So 2, 7, 9 and 10 are the vitamin D dependent clotting factors. Warfarin blocks them so that the liver can't produce clotting factors. And so that's the way it works. And basically, it's an interesting story. The way it was discovered is that in early 1920s, I think it was, there was a farmer in Wisconsin in the US who noticed that every time his cows went into this particular field and ate the clover there, they basically died with blood coming out their mouths. And so he took a dead cow and he took the clover and he said to the scientists at the Wisconsin Alumni Foundation, what the hell's going on here? Work out what's happening. and they worked out that the compound